Welcome to the Physician Associate Podcast.
Hello and welcome to this episode of the Physician Associate Podcast. My name is James. Today I am delighted to be joined by PA George Rout, who is a Physician Associate in Cardiology. Welcome to the show, George.
Hello, James. How are you?
Very well, thank you. Thanks for coming on the podcast.
Absolute pleasure.
Do you want to start by introducing yourself and telling us about your life before you became a PA?
Yeah, sure. So I'm George. I'm the cardiology PA at West Suffolk Hospital. West Suffolk Hospital is based in Bury St Edmunds. And so I'm a Bury boy. And then I left Bury, went to London, studied biomedical science at the University of Roehampton. Quite quickly decided that it isn't what I wanted to do. I didn't want to be in the labs. So I came home and with a mixture of trying to find out what I wanted to do, a bit of traveling here and there. I became a healthcare assistant at West Suffolk. And at that point, the PA course was sort of talking the PA course at UEA was in its infancy, and there was an advertised master's course there, which sort of fit in with the direction of travel I wanted to go. I wanted to be more clinical. I wanted more people interaction, but I also wanted to use my biomedical science degree. I mean, it helped that also I was able to stay at home and sort of commute to UEA and get to know the trust as well. So you could say really, I didn't leave my first degree wanting to be a physician associate, but it answered every question I had. It gave me a direction into a different route of medicine. Obviously, graduate medicine's there, but it wasn't necessarily for me at that time.
Did you know that you wanted to do cardiology from day one as a PA student, or how did you fall into cardiology?
I think day one is probably a little early. I think even through biomedical science, I found sort of cardiology the most interesting. I always found that, I could read about that without thinking it's revision. Going into the first sort of term, I'd say, of PA school, I always found the cardiology cases the most interesting. I was excited for my cardiology placement. And like I said, the lectures on cardiology were the most enjoyable. And I think when you as a graduate, with a bit of life experience, you understand that, it's not like you have to turn up to maths, English and science. So when you start getting taught something you're interested in, life becomes much easier. And I think then I was very lucky when I went to my cardiology placement. We sat in a consultant's office, Dr. Sherry's office, and she just wrote down everything that cardiology does. And we were there for 2 weeks, and she said, you can go to whatever you want, just plan it out. And it was just cherry picking, and it was great. And we had such a good week. They taught us loads, from CCU ward rounds to echoes to angios, these sort of things where you can build a whole clinical picture quite quickly. It wasn't just the medical team as well. It was sort of the interactions I'd had with specialist nurses. You just think, well, actually, these nurses have paved their career out of, heart failure nurses, nurse-led cardioversions. You think there's opportunity there for sort of the non-stereotypical, medical sort of position. I think that is when you get that sort of instant impact and you're sort of being a student in cardiology, it's always like, yeah, okay, I really enjoy this. This department here is keen to progress non-medical members of staff, and also having those sort of early interactions with the lead consultant who gave me the impression that she wanted PAs in the department, and that sort of just fueled me quite early on.
Is it fair to say you had to carve out your own niche and job role? You went to some quite extreme lengths to impress the cardiology team to get the job?
Extreme length, yeah, I suppose you could say that. Well, I think what I decided to do was just be a bit of a nuisance and be a proactive nuisance. I think that was probably the best way I could describe it. Throughout, if there was ever a cardiology patient, they were the ones I was picking up. In our second year, we've obviously got to do our health improvement project, our big sort of project at the end. So day one, I was knocking on the consultant's door and I said, okay, what projects are you doing? And we came up with a great idea. Then 2 days later, she said, actually, I've got a bigger one. I'm doing, she's working for NHS England. It was to do with the primary care pathways for atrial fibrillation. Do I want to get involved? And I was like, of course I want to get involved. So I was just sort of creating a relationship and showing you how sort of proactive and and also effective PAs can be as well. And she really helped me. She allowed me to, like I say, get involved in the cardiology department. And then I think you see other jobs that come out with these beautiful timetables of what they want the PA to do. They want holes to fill in, but actually cardiology decided they just want a PA and see where it goes. They're new, they're excited. Let's see what we can do with this sort of PA who's obviously very keen, and we haven't necessarily got a direct route to take him, but let's see what happens. And because of that, it allowed me to have quite a lot of ownership and direction in taking the role where I wanted, but also understanding, so basically my first couple of months I was on the wards, I was dealing with the junior doctors, the F1s, F2, understanding what sort of stuff came in. And then I'd move up, I did CCU for a year and a half, and I stood next to the consultant, the lead pharmacist, and another IMT doctor, and we did CCU. And then I was learning every day. And then that got to a point, well, actually, I can't just be on CCU forever, because we wanted to bring other junior doctors in to experience CCU. So I said, what next can I do? Okay, well, you're getting 20 plus referrals a day. Your registrars are doing this. Can I just see referrals? That then allows me to see the patient, review the patient, discuss the patient, follow up the patient. I'm learning to echo, so I can scan the patient. I can do so much more before a consultant sees the patient, and then I'm handing over. So my role is always changing, and I've always sort of taken the initiative and trying to find where I can develop myself, but also see an opportunity in the ward and see where that needs to be fixed.
Being proactive and seeing where the opportunities lie really allow the PAs to develop, don't they? And if you're good at that kind of blue sky thinking, and you've got some consultants on your side that are up for it, you can really carve out your own path.
I think it's one of our biggest selling points. You've got everyone rotates doctor wise except for a few. You've got a nursing staff that do weekends, do nights, and there are very few PAs. So you're probably most likely the only PA. So you build up this relationship with a consultant, or we have 6 consultants, and I have a different relationship with each of those consultants. And each of them like me doing different parts during their week, because they're on a weekly rotation. That takes a bit of time. You have to prove yourself. I mean, coming in as a new PA is very difficult to start demanding those things. But once they understand what you are and what you can and can't do, and then you have that first rotation, everyone changes, but you're still there. You'll soon find that actually, what you can offer them and the wards, that continuity. And they say, well, actually, that needs fixing, or that needs filling that hole. How can we develop George, the PA, to sort of help run the department? That also repays. The amount of junior doctors that I see now, I'm on my 3.5 years, so there's at least 3 full rotations plus all the F1 and 2 rotations. They all come through, and I'm able to offer them support and teaching. And I think that's really well understood in cardiology, that actually if they invest in me, it subsequently means I can then relay that onto these sort of rotating doctors.
Absolutely. And that continuity of care will be so important in a specialty like cardiology, where I guess you might see the same patients come in and out of your service over years. You'll know when they're well, you'll know when they're sick, you'll know what needs doing to make them better again. Absolutely.
And I think I've seen patients frequently that are readmitted, and it might not be a case of that I see them, but I'll see their referral, for example, and then I can say, I reviewed that chap 2 years ago, and that's not how he presented. So the benefits of having a PA within the system, it just helps everyone with that continuity. And it's not necessarily reviewing the patient every time. It's just, like you said, understanding when they're sick, when they're not. All that's different from last time. And also, it's not just the patient. There's been multiple times where it's the families as well. The fact that they see a familiar face and they come back and they said, this is what they told us last time, what's changed? And then you can sort of offer that reassurance or that extra explanation. And it just gives another layer to the patient care.
Do you mind talking to us about what those first sort of few days, few weeks, few months were really like coming out of PA school and starting your first job? Just thinking for any PA students who might be coming up to graduating soon, what hints and tips and experiences we can learn from you?
I think what you've got to do is first find the right job. Understand the job before you go into it. Know what support systems in place. Know what's expected from you. I think when I arrived, I was very lucky. I had 4 weeks or about 3 weeks of induction. And that involved sort of a bit of the cath lab, a bit of the echo, a bit of consultant ward round shadowing, some of the specialistness. And I actually took that opportunity to introduce myself to everyone. So they knew where I stood from the day I started properly working when I was on the wards. So I think that was made a huge help for me, because then it also, this sort of orientation, because it allowed me to focus on really introducing my role and introducing how I can help the ward. I mean, I didn't have the experience to back it up. So therefore I had to sort of, create an environment where I didn't feel pressured to be much better than I was, because I didn't have the experience. And luckily, like those that work in the NHS and you work in a good department, people accept you for what you are. And as long as you communicate, and the junior doctors I had were brilliant. Some of them took me under their wing, just taught me the basics. And then I think I joined about 3 months before the first rotation. So those 2 months I was an absolute baby. I was treated like a baby, and it was great. I learned so much in those 2 months, because everyone had got, 2 months experience, or 2 or 3 months experience in cardiology. And then all of a sudden, when they rotated, I was one of the most experienced ones on the ward. And that to me was one of the most difficult things. A huge mental shift to go, actually, I need to, progress quicker maybe, or like come out of that whole mindset of being, I'm just here to learn. And I think that was the most challenging bit. But what got me through that was probably the 2 months before prepared me for that. And I think that's what you got to remember, that you're not coming out with a finished article. And as long as you surround yourself with very positive and helpful people, and you don't be fearful of saying, I don't know, or what does that mean? And, exposing yourself to a potential stupid question, because that's how you learn at the end of the day. And I think if you can get over that hurdle quite quickly, you'll learn so much quicker than if you sort of keep quiet and try and pretend like you know what you're doing just because you've graduated, because the real learning starts afterwards. But what you've got to do is just make sure that you create an environment where you're safe.
Absolutely. The old adage, isn't it? You get back what you put in. If you show you're keen, introduce yourself to everybody, get stuck in with the work.
Yeah. You
get so much more. I've often tried to explain how PAs and doctors are different in terms of our utility. So for an F1 and a junior doctor, it's very important that they rotate and change departments and change specialties for their learning, for their training, and they move hospitals regularly. For a PA who's permanently in post, 12 months in that post, you're going to have soaked up so much knowledge and absorbed so much about how that department works and how the system works that you're within. You're going to be an entirely different beast compared to the doctor that has rotated around and done 3 other jobs at that point.
Yeah, I think that's an interesting point. I think I always try and separate myself, and I don't like it when people sort of say, what level are you at? What level do you feel you're at? I'm a cardiology PA. The reason I'm here is that I don't move. I'm employed by cardiology. We don't have this very obvious vertical progression that doctors have, but I think that's fantastic. They should all, that shouldn't necessarily be changed. I think it works really well. But I think what PAs should do, and I encourage them all to do, is to progress. And, if you're on the wards doing the same thing for a year, you've got to look at yourself and go, okay, can I do this for another 5 years? No, you can't. So, look at what the next level of doctors doing and what they should be doing, and use that as like, okay, what should I be doing? I think it's easy for cardiology for me, because I've obviously gone in there with the motivation of wanting to work in cardiology and know exactly where I want to be, or the skills I want to have after 5 years, let's say. And because of that, it's been quite easy for me to go, look, I've done this. Can I do this? Can I add this to my job? Can I add this to my job? And that sort of creates my progression. It's difficult. I'm not one to sort of overly compare with sort of rotating doctors, but I think what I enjoy is the rotation of doctors, because every doctor that comes teaches me something new. I think the IMT3 role is a very interesting role at the moment. These are highly experienced doctors that don't necessarily want to be cardiology. We've had a very exceptional doctor who's just gone into neurology training. So for me, that only really sees cardiology, and as you know, currently at the moment we have to recertify. So, I'm just there asking him neurology questions as well, just trying to feed off them. So it swings around about because then he's asking me cardiology questions because he's not done cardiology for a while. So you have to have these different levels of experience, and I think as well as different roles. And I think that's what really makes the PA role very integral to, well, I'm a massive advocate for specialist PAs because I think they've got so much scope. And like you said, after 12 months, that's a huge amount of knowledge that they can accumulate on a sort of basic shop floor level that they can just distribute to all rotating doctors.
Absolutely. It's that collaboration, isn't it? Rather than being
absolutely always
competition, it's how we can help
correct.
each other. And I think you hit the nail on the head. It's best not to compare PAs to native doctors. And I really try not to do it as well because we do train and work and learn differently. We're very much different beasts.
Yeah.
After a while. So.
For sure.
With that in mind, there is a question around whether physician associates should have postgraduate specialism qualifications, exams in cardiology to get a certificate of competence or knowledge in cardiology and other specialties. At the moment, they don't exist. What are your thoughts on?
So I think my thoughts are that the current situation of recertification would test me on specialties I'm not training in at the moment. So I would find that a bit odd to lose my job. I understand why we do it. If I don't, if I obviously do well in the cardiology part, but not well in the rest, I technically can't work in cardiology. So I find that very difficult. In regards to sort of post or specialist exams, I think why not? Why not get to a point where you can differentiate a newly qualified cardiology PA to a senior cardiology PA, and you can even go into subspecialties if I wanted to be a congenital specialist or something. Not that I do, but you need a way to sort of be able to differentiate that and prove that you've got that. I think for me, and I touched on it before, I'm learning to do echoes, and I think that was one of the things that I looked at and I said, well, what can I get in the next 5 years that's a qualification to say that I'm improving? That's an accredited course that involves examinations, logbooks, and a practical exam. And I know in 3 years' time, I'm going to come out with a substantial qualification, which then I can go to whoever, be it my appraisal or the next job, whatever it is. I can say, look, I've got this post-qualification examination. So I wouldn't say no to the opportunity to be able to prove myself by post-qualification exams. And I think, I'm sure other specialty PAs wouldn't either. But I think it's definitely something for the future, for sure.
I guess my worry is that they can sometimes become a barrier to entry. So I don't know, but I'm thinking down the line whether it would stop people going into cardiology or stop you being able to apply for a certain job because you didn't have this qualification.
But are you saying then you need the qualification to get a PA job?
Potentially, I could see a situation where that arises.
Well, then that's an interesting take on it. I hadn't thought about that. But then I guess if it was me and I said, well, I want to do cardiology, and I said, how am I going to get that? Okay, I need to pass an exam. That's fine. I'm happy to do that. So I guess you're right. You're sort of you're bottlenecking certain people from a specialty. Whereas actually, if it was more of a 5-6 years down the line thing, you can sort of make a choice, a professional choice, whether or not you want to take that step.
Yeah, it's an interesting debate, isn't it? I don't know how the profession will evolve. It's what if you decide you want to change specialties down the line, you might preclude from being able to switch that easily. You've mentioned quite a lot of the sort of advanced skills that you've been picking up. How did you get into echo, and what advice have you got for anyone else in cardiology who might want to follow in your footsteps?
So when I went from doing CCU ward rounds and then seeing referrals, we sort of ended up getting these small handheld V scanners, so the sort of handheld echo machines. And some of our other registrar colleagues who are trained in echo were using them. And it's another tool. It's another diagnostic tool. It gives you a quick window into when you review your patient and you're not sure what their heart's doing, what their LV functions like. It just allows you that little bit of extra information to then go discuss with the consultant or, suggest plans or make immediate decisions with the current team around. So I think when you start looking at it and you go, wow, I need to learn this skill quite quickly. And then it just sort of blossomed from there, really. I've got a very supportive consultant who's he's on part of the British Society of Echocardiogram. I've got a fantastic diagnostic department who are inundated with inpatient referrals. So then once you start sort of building the picture of the demands there, and then you sell the idea of, well, actually, I can reduce that demand by hopefully doing more echoes. When I review patients, I can do quick echoes to save those inpatient referrals. But on the flip side as well, like if you teach me how to get full accreditation, then why not can I help the department as an outpatient? So currently I run a supervised outpatient list, and I also help with the inpatient full echoes at the moment, as well as using my echo during my review. So I've now created a situation where I'm probably scanning most days and talking about it with, be it registrars, the diagnostic department or consultant. So any people that want to get involved in it, you just have to sort of, again, it's be proactive, isn't it? Look at courses out there, look at what equipment you've got around you. You know, I think all ED departments will have an ultrasound scan, I think. You know, follow the people that can do it. I try and find, some of the junior doctors that come through cardiology ultimately want to do cardiology. And they always say, can I scan? Can I watch you scan? I say, well, absolutely. Let's go scan together. I'll teach you. I can teach them very basic things. But it just whets the appetite. And then they leave with that sort of, okay, yeah, I've learned something. And what course is that? Yeah, okay, fine. I'll book myself onto that course. And I think that's what you've got to do. You've just got to be, again, proactive and seek opportunities.
And what does the future hold for you in cardiology next? I know you're moving on to sort of running some outpatient clinic work.
Yeah, so I think for me, I've always, it's a bit easier in cardiology. There's obviously, as you and most of your listeners probably know, we don't prescribe. So that structured a lot of my sort of short-term plan. So obviously echo, no medications involved. It's very non-invasive. It's ultrasound. So it's completely within my remit and I can do. So I've been very fortunate enough that another consultant has worked for PAs previously, and he's very keen to push me in a different direction rather than ultrasound. He wants me to get involved in outpatient clinics. So I've only done one, but it's always been part of my plan to, I think that's a completely different way of thinking, outpatients compared to inpatients. So it's something I've not necessarily had loads of experience in, but I sort of grabbed this opportunity to run his clinic whenever he would like me to. Obviously, with his full support, we discuss the patients sometimes pre and always afterwards. And then because of how the clinics run and also COVID, there's not so much immediate prescribing needed. So because we can discuss, it's a limited clinic, I think maximum patients of about 5. We can discuss those. I can discuss my clinical findings, my history, the letter I've written. And if he agrees with it, then we can suggest what medications to the GP. And because of that opportunity, I'm now getting inpatient experience, outpatient experience. I'm learning how to scan. So I'm starting to tick boxes of these different opportunities. And I think obviously the natural thing that I'm not currently involved in is the cath lab, the angio suite, which I think is probably a little bit further down the line if it does, just because we're a small centre. We run one lab. There's a lot of pacing that happens in our clinic, and I'm not necessarily currently too interested in that. But obviously, I keep my ears open and try and learn as much as I can. But there's not saying there's ILRs that need implanting and removing. We're just training a nurse up at the moment who's removing them. But the demand for those is going up. So of course, the more you put in, the more you've got to take out. So that there could potentially be opportunity there. But I think, if you remove clinical things as well, you've got to look at, okay, teaching. I'd love, I'm trying my best to do a bit more teaching. I'm trying to get myself more involved in leadership and management. I think you've got to not only focus on clinical. When you're talking about progression, what's next? I think there will be a part, there will be a time where you'll have senior PAs, lead PAs, and I'm sure many trusts are doing that already. And that's way more than just your clinical experience.
For many people, sometimes they get a bit hung up on the fact that physician associates at the moment, we're unregulated as a profession. And we know that's going to change. The GMC is going to regulate PAs. But at the moment, we're unregulated. At the moment, we can't prescribe. And at the moment, we can't order X-rays and sort of CT scans with ionizing radiation. Day to day in your life as a cardiology PA, is that a huge barrier in your practice?
So absolutely not. It doesn't impact me. And I think that's, again, coming down to the environment and the team around me. They understand my limitations. But then also, echo doesn't involve any prescribing, and the referrals I see, I discuss them. They're suggested plans, or if it's an acute setting, then there are multiple people around at the same time. And when I was less experienced on the ward, you just have to be honest with the team around you, understand. They need to understand your limitations, but I'll write that discharge summary. Can you prescribe those TTOs? We're both looking after the same patient. So it's a give-take world. Never did I just demand anyone to prescribe me any medications. I made sure they were comfortable. And if they weren't comfortable, then you find someone that you can explain your position in. And I think, again, it comes down to just, you've got to be open about that, have the conversations, and find people that understand your role and your knowledge. And I've had many doctors that have asked me to explain the clinical scenario, why that drug, and I'm happy to do that, because I think as a PA, you need to, if you're going to be talking about drugs, you need to understand why you're prescribing them, and if they're not happy, then they will say so, and they may review the patient with you, but then you should go with them and also try and learn from it. So it's not a limitation anyway. If anything, it's allowed me to sort of, like I said, go into echo, because that was it sort of directed me in different ways. But I open regulation with open arms, and when and if we're able to prescribe, I'm excited to do that also.
Brilliant, thank you, George. What is it about cardiology that fires you up? What is the best thing about working in cardiology? Why cardiology over any other specialty? It's
an easy question, I think. For me, the variety of patients you see, it covers, old, new, young, not new patients, old and young patients, the acute versus the chronic. It has an involvement in multiple other specialties, the way the lungs and the heart are connected, and that sort of bounce off between cardiology and respiratory. It's the very acute to, the ALS, to, flash pulmonary edema. And then it's not only, it doesn't finish there. You have to go, okay, why has that happened? So then you get the depth as well. I speak it to a patients a lot about, let's take ACS, and STEMIs, for example. People understand the basic structure of the heart, so you can make it really easily digestible for them. So you can really speak to your patients as well and make sure they understand that what you're doing and what's going to happen. And then also it brings it back to a non-clinical, so lifestyle modification. So you can really hit home on different points. So it's that sort of breadth of different angles you can take, the simplicity of it, the complexity of it, and then also, the massive subspecialties depending on what sort of hospitals you're at, and all these patients. So every day, there's always something new to learn. It's all very different. And when you think you've seen it all, something else turns up. It will blow your mind. So that's why I enjoy it, and that's why I don't plan on leaving it anytime soon.
I'm sure there'll be a lot of PA students listening to that who get fired up as well for the same reasons.
Yeah.
Not only do you spend your day job fixing broken hearts for a living, you also raise money for Heart Foundation charities as well, don't you?
Yeah. Once upon a time, I ran the London Marathon for British Heart Foundation. That's correct.
Amazing effort, and raised quite a lot of money, didn't you?
For me, it was a significant amount of money, but it was an easy sell. I think it's as I said, everyone's got a heart, and it was an easy opportunity to raise money for charity. I was very passionate about it, and also challenge myself at the same time. So it was, for a great cause.
And keeps your own heart healthy as well with all that.
Absolutely,
exercise.
Exactly. That was that's always helpful.
If people have heard this episode, they maybe have questions about physician associates, and in particular PAs working in cardiology. They may have ideas or want to find out a bit more information. Where would you point people to go to find out more?
So if they want to learn about PAs in particular, your podcast is a fantastic example of what we can do. It's great guests there. In particular, the urology one, I was fascinated about that one. And then for cardiology in particular, just go to your next placement department, find the cardiologist, say you're interested, see what they can offer, and you'll see there's so much to see. And especially if you're at a tertiary centre, or you'll find that people in cardiology are a particular kind of, I mean, to be fair, I'm sure all specialties are very keen on their specialty, but I found cardiologists in particular are very enthusiastic, and they want to teach, and they want people to join cardiology. So just keep asking the questions, keep poking, see what sort of opportunities, things you can see. And then if you wanted to learn more from an online perspective, obviously there's the usual NICE guidelines, European Society of Cardiology guidelines. Something that I'm really enjoying at the moment is a website called ECG Waves. I think it's not too expensive, but it makes ECGs very digestible. The way they've laid it out is fantastic, but also echo as well. There's some really good stuff on there. But I think on the subject of ECGs, just take an ECG to someone that wants, that likes ECGs. Take it to a cardiology reg or a consultant or a cardiology PA. I encourage anyone to bring me an ECG, because if I don't know the answer, I want to know the answer. So I'm always happy to sort of sit down and read an ECG with someone if they're sort of a little bit confused about it.
Brilliant. Thank you, George. Thanks so much for coming on the podcast.
Awesome, dude. That was fun.
And thanks to you for listening as well. I hope that was a really interesting episode for finding out more about physician associates in cardiology. If you're a PA or a PA student, if you've got a particularly interesting job or a cool idea for another episode of the Physician Associate Podcast, I would love to hear from you. Please get in touch. I'm on social media at PA Podcast UK, and I hope you'll join me again for the next episode.
Thanks for listening to the Physician Associate Podcast.